One. Hello, everyone. Thank you for being here. Thank you for your time and dedication in wanting to learn something new. It is always appreciated. Today, we're going to be talking about overdoses. How do they affect our loved ones? And this is in honor of International Overdose Awareness Day happening on Tuesday, the 31st. The Mercer Council is hosting it in Lawrenceville, but there are many different places that are also hosting similar events. So I have with me today Family Support Coordinator Rocky Schwartz and Family Support Advocate Vanessa Peters. So I'm going to be talking about them both just for a second because I feel like they need to be honored in such a way. So first thing, for anyone that doesn't know me, hi, my name is Ruth Delpino. It's been a while. I'm a prevention educator at the Mercer Council on Alcoholism and Drug Addiction. I'm the Mercer County Grant Program Coordinator. I have a Bachelor of Arts in Global Studies, Political Science, American Studies. In American Studies, I'm certified in teaching English as a foreign language, life skills training, and leadership. And we will be talking about Rocky Schwartz. She's the Family Support Coordinator at Sharing the Hope Family Support Center for the Central Region of New Jersey. I believe it's Mercer, Somerset, and Middlesex, if I'm not mistaken.
And Ocean. Union, and Middlesex.
Okay, all right, thank you.
Excuse me.
So they cover a broad range of New Jersey, which obviously is very needed. So Rocky does have a lot of different accolades to her name. And I think one of the most interesting things is that she's been in this process for a very long time, is someone who was a family member in recovery, who was a person in recovery, and all those aspects. Also is a certified yoga teacher and a wellness coach, has a wellness coaching certification. So I am very excited to see how that plays into the way that you do things, which is really cool. And I love that Rocky has been in this for a long time, and she's dedicated her whole life to making people's lives better. So we're gonna honor Rocky in that way. Next, we have Vanessa Peters. She's the Family Support Advocate at Sharing the Hope, a family support center in Central Region, New Jersey, which also covers all of those counties as well. And Vanessa has always wanted to help others, which is awesome. Actually graduated from Hillsdale College, and it was part of a military family, which is very interesting because we do have that in common. Also has been someone working in this field and struggles with the concepts of mental health disorder and substance use disorders, and does her best to give back to the community. So thank you for being here. Also, both of them are mothers and have used that to inform their experiences. So I think that is a beautiful thing. Anything to add?
I'm impressed by your credentials, young lady.
Thank you.
I'm honored to be here.
Yes, of course. So we do have some disclaimers just because we always want to start with setting the ground rules and making sure that this is a space that people can share and that people can understand where we're coming from. That we first started talking about, we will be talking about some hard realities. We're talking about overdoses. These are people who struggle with substance use disorders, mental health disorders, and things happen to anyone and everyone at any time, at any point. This is speaking on experiences of personal and professional alike. So some of our personal experiences will inform what we say professionally, but in its own right, it's all empirical. One experience does not mean it speaks for all experiences. It can happen to anyone and no one is above it. We want to make sure we honor all of the experiences that anybody has. There will be mentions of suicide, and suicide prevention will be addressed throughout the presentation, just as a brief disclaimer to let people know that these are the things that we are talking about because they are important for us to inform the way that we present the information. So we'll be getting started on this. So what happened this year? A lot. And I think that anybody here knows why we're on Zoom. Anybody here knows why we have to do things virtually and we do things differently, but we're still doing what we can. Because everything had changed, and the lack of resources and the resources in general did change the way that people interacted with their environment. So people at the Family Support Center, what did you see? How were the resources changed? What were the things that you sort of have seen throughout the experiences that you worked with your clients?
Well, I think there's so many of them, but
yes.
One of the biggest things that happened, and it was in the last year and a half, actually, since the pandemic began, was the initial shutdown of all the treatment programs. And then over time, everybody figured out how to do things virtually, and licensing was, telemedicine was made available, but there is still less access to treatment. And also, not everybody, in many cases, people don't want to be in treatment initially. I can say that for myself, my own experience. And so not engaging in person and just doing it through a computer screen is very, very challenging. Also, the mutual aid support groups that some of our family members went to, like we have a weekly support group, but we went virtual. Same with other support groups such as Al-Anon or Nar-Anon or Families Anonymous. So that connection piece was taken away initially. And we also saw that some of our family members, their loved one was incarcerated and then quickly discharged due to COVID, with no discharge planning. And so some of them were sent home immediately. They were not sent to treatment, which was initially part of their sentence. And it created a huge vacuum where families suddenly were put in a caretaking position almost overnight. So many resources were taken away.
That's so hard. And what I think is so interesting, especially at the council, what we say is that the opposite of addiction is not rehab or any sort of drug facility, it's connection. And to make sure that people keep those connections in a way that is constructive and helps them connect back with the people that care about them, but also connecting to themselves again, because they may feel disarrayed in a lot of capacities. So we sort of explained why, but we also could be talking about the numbers. And this is something that I do want to say can be triggering for some people. So anybody that's watching this on YouTube, I will put a timestamp that you can go to ahead so that you don't have to listen to too much of this. But while we're here, we're going to be talking about it. And Rocky, you did have some things to say about the Narcan deployments. And I wanted to, that when we were first looking at this, that I said, their drug overdose deaths in the United States rose 29.4% in 2020, and an estimated of 93,000. And of those 93,000, about 70,000 included opioids in some capacity. But this is some preliminary data, right? And it did go up about 5%, which increased from 2019. And now what I find interesting, and something that I didn't really consider because this isn't necessarily something you think about, is that the Narcan deployments were really only counted for people that officially had them. So it was really medical staff and law enforcement. Am I not mistaken?
That's correct.
Yeah. So I thought that was really interesting. So when we're talking about the underreported numbers, we're not only talking about people who struggle with homelessness. We're not only talking about people who just sort of go under the radar. We're also talking about Narcan deployments and people that had to use them because of overdoses that did it in a home, that, where people who were parents or caretakers that use Narcan and that person decided not to go to the hospital, or there was just some way that it wasn't counted. And those are also numbers that we should take into account too, to understand that there is a gravity to this, that there is a gravity to the amount of numbers that are not being reported. So I'm going to click on this, and then we can sort of go through some of this over here. Rocky is great at reading some of these things, so we're going to go through this. So we're going to do data by county, and this is the NJOAG.gov, and you can look through this, and you can really just go county by county. So we're going to go to Mercer, and then we're going to read through Mercer's stats here. So Rocky, you can take it away.
So can you just let me just see the top just a moment?
Yes.
Okay, so we're very fortunate that the Attorney General now has this is the dashboard where they collect all of the data. The data that's on here, I hate talking about data because these are people. And each one of these numbers has a family and a community associated with it. So I want to honor that, because sometimes in the prevention world, we just talk about data and numbers, and these are people. These are our loved ones. But So the Attorney General in New Jersey started collecting this data in 2013. And these, to date, this is as of June 30th, I believe, at the very top, the suspected overdose deaths for Mercer County, there have been 128 deaths. Those are deaths that have been determined by the medical examiner's office. And there's typically a big lag because it takes about 2 months to get the toxicology back. The good news is there are 574 Narcan administrations, also called naloxone. As you mentioned, those are ones that have only been deployed by law enforcement and EMTs. However, that is a really good number. It's already exceeded, if you look at 2019, 534. So if you look year over year, the good news is naloxone administrations have increased dramatically. So we are getting Narcan in people's hands. And that's one of the things that we promote in family support. And we've even delivered Narcan to someone if they've utilized it on their loved one and they don't have time to get it refilled. It also is tracking the opioid prescriptions, because I don't know how many people know that most of the heroin users today, they didn't start from heroin, it got started from a prescription opioid. And there's been a concerted effort to reduce the number of opioid prescriptions that have been dispensed. And you can see from 2013 up to today, actually, how dramatically that number has gone down. A lot of that is due to what's called the PMP, the Prescription Monitoring Program, and it eliminates the ability to do doctor shopping. So there's a lot of good news here in terms of prevention efforts. Sadly, deaths are increasing. Our overdose deaths are increasing, as you said, and fentanyl has a very, very big contributor to that number.
Yeah. And we will be talking about fentanyl. Like, we have a whole slide for it just because it is such an important part of this conversation. So thank you, Rocky. This is hard stuff to talk about, but this is good numbers for us to know so that we know where the discrepancies are to further our resources in those areas. So also, Vanessa, we did talk about the stimulus checks that people had gotten. So you actually brought this up when we were talking about it. How did that play a role in in how that changed people's interaction with overdoses and drug usage?
Oh, yeah. So we were just talking about people getting the stimulus checks and then having extra cash, extra expendable income, and unfortunately choosing to use that for substances. And we saw that with my previous position, I saw that with people that I worked with as well, with participants.
Yeah, and I think that's got to be so hard because that's something that's meant to help, and obviously people use the money how they want to. But that's just an interesting dynamic to it that not a lot of people think about. That when people think about weather, they don't think about people who don't have shelter. When people think about food, they don't usually think about people who don't have food. And when people have money, sometimes people don't think about who has the money but may not use it the right way, or may not use it in a way that's good for them. So that's just another aspect to it. That's neither good nor bad necessarily to receive money, but just talking about it is an interesting concept itself. So thank you, Vanessa. So we're going to be talking about a substance use disorder. And once again, we're sort of going to go through this a little bit. And the reason why we're doing this is to set the basis for why we are talking about the things we talk about. And once again, a substance use disorder and addiction are it's sort of like a rectangle, a square being a rectangle, and a rectangle is not a square. It's one is the other, but one is not the other. So when we talk about substance use disorder, we're talking about a range of behaviors and opportunities and environment that a person exists in for them to interact with a substance. So it could be usage over time. It could be usage with a certain person. It could be usage, based on a situation or an emotion someone feels. Those are very complicated things, right? And all of those things sort of lead up to, and it's a scale here where you lead up to intervention and where you lead to many different points of that intervention. So addiction is an end point, not necessarily the end, but the pinnacle point of a substance use disorder, where someone's body and is dependent completely on a substance. So addiction in its own right is a very hard reality to have, but it also is something to note that when you have these behaviors, there are many points where you can say, hey, let's get you help, or hey, let's work on this together, or hey, let's find something that will help you with your substance use disorder. So it's not saying that if you have an addiction, that's it, you're done. It's saying that if you have an addiction, there are many places and people and things that can help you with that process. So that's my spiel on that. So take it away.
Yeah, I was going to speak to the co-occurring. And basically what we know is that about 50 to 75% of people with an SUD also have a co-occurring mental health challenge. And basically what we know is that, using a substance may be a way of coping with a mental health challenge. And, I'll speak from my own experience. I'm a person in recovery from a substance use disorder, but also from bipolar disorder. And I was undiagnosed. So for a period of time, I was using opioids and other substances to basically self-medicate. And sometimes, an individual with a co-occurring disorder might feel worse after detox because the symptoms of their mental illness will kind of come back in full force. And that's why it's important to get, professional psychiatric help and the appropriate medications. And for me, that also included, therapy and recovery plan and other things, and so basically just that's kind of the way the co-occurring plays into the understanding of a substance use disorder.
Yeah. Those are all I find it so interesting that there's such a correlation and the numbers are so overlapping. And the overlap there is where we can find a lot of a point of intervention, a point of giving resources to those people. So I think that is an interesting aspect to a substance use disorder.
And Ruth, I just wanted to say, for youth, many young people who have ADHD, ADD, some anxiety, and just to go back to the prior slide, like what has happened in the last year plus, the levels of anxiety and depression have gone up so tremendously that is another reason why this co-occurring issue is so significant, and we're probably seeing more and more cases because you want to self-medicate, calm down that anxiety, calm down that fear.
Yeah, and that's just such an interesting part to me, but also something that I think when we're looking at it, we can also understand that that's where the resources should go. There's a gap in how that, like how people can pursue treatment. There's a gap in how people satiate their disorders. So making sure that we can have those resources to those gaps and filling them in to make sure that people don't fall through the cracks. So also, Rocky, you sort of wanted to talk about codependency, and I just find it interesting because I've found this concept, I don't usually hear this, and so I'm interested to learn more about what that means.
So I am not fond of the word codependent or an enabler. I have personal experience with this. I'm a woman in long-term recovery. I'm also a family member in recovery, and I've attended many family programs that the fingers are pointed and you are an enabler and you did this wrong and you did that wrong. You're too enmeshed in your kid's life. In our organization, we consider those bad words and we don't use them because number one, codependency is not even a diagnosable condition. And it's thrown around by professionals all the time. There's nothing in the DSM about it. Enabling, it is a label, and it's a judgmental label because family members that are dealing with a loved one who has a substance use disorder are already feeling less than, doubting themselves, feeling shame. And then to be labeled something like this, it's just another way of judging them. And what we now know is everybody's doing the best they can. Can we give them new skills? Absolutely. But they don't need to be judged anymore. And by the way, what works for one family member doesn't always work for another one. The circumstances change. Tough love and throwing people out in the street isn't always the right decision to make, especially with the fentanyl and the opioid crisis that we have. This is a life or death issue. And it's not just black and white like that. There is a tremendous amount of gray. So I get a little carried away. I get very passionate about this.
It's a good thing though. Yeah. And so when we sort of use, we don't want to label family members, right? So in your organization, what do you think would be the best sort of like, instead of this, what's another word that we can use, or what's another approach that people can use it with?
I just call them what their role is in the family: a mom, a dad, an older sister. There's no need to call them a codependent, because that implies pathology and negativity.
Okay. That's really great. And, you know, I learned something new today, and I'm glad that we discussed that, because, you know, when we're discussing it as prevention educators, as people who work with this stuff, using the best language and using the right language really changes the way that person interacts with you, but also the way that you interact with other people. So I love that we're sort of rounding out some of those antiquated terms here. So we're going to be talking about prescriptions. There are a lot of different areas, and I have a great video that I will not play, but it is something that discusses a lot of the prescriptions in the United States here. So we have commonly prescribed opioids, and there is a huge list here. Are there any discrepancies or anything that you both would like to discuss? So yeah, these prescriptions are kind of self-explanatory. I'm sure everyone has seen these or interacted with one of these in some capacity at some point in your lives. I know, for example, I had hip surgery when I was 10 years old, and I had a morphine pump when I was 10. So and it was just something that was normal back then. And I just didn't think that morphine would be something that a 10-year-old could use, but it's very possible. And I know people who just use it for pain management, and pain relief is something real. Pain relief is something that people search for and use these to get through day-to-day life. And that is something that is very valid. And wanting to address your pain is not something that can be villainized, but it is also something that when we address our pain, to make sure that we're using the right things and that we're using the best tools so that we can take care of our bodies now and in the future. So there is one particular drug on here that we will be talking about in the next slide, and it is fentanyl. And just be prepared, because we got a lot about fentanyl on here, and I'm sure there's a lot to say about it, because it is the new thing. It's the thing that is unprecedented and something we've not seen before, because of the intensity of this drug, because of the way it interacts with the body, because of how easy it is to mix with other things. So why is it an issue now? I think this is something for either Vanessa or Rocky to answer, that why is fentanyl an issue now? What is it? What's new about it? What's interesting about it? Why is it something that is coming to the forefront right now?
Well, the fentanyl that was mentioned in the prior slide is something that is prescribed in a hospital typically. This is different. This is a synthetic product that's shipped from overseas, and that is it's devastating, because over 90%, up to 95% of the counties in New Jersey, when someone is arrested and they are able to take the drugs that are on hand, it's sent to a state lab, and 90 to 95%, depending on what county you're in New Jersey, whether it's counterfeit pills or whether it's heroin, has fentanyl mixed in it. And why do people do that? It's cheaper to make a counterfeit pill. You can buy a pill press that can make thousands and thousands of pills a day in your garage. You can buy the pill press online. You can buy the fentanyl online. You mix it with other things and sell it as a Xanax bar, for example, and it looks just like it. So it's a huge issue now because people may think, kids may think, you know, they're buying a Xanax pill from a friend. It's not just kids, but people who became addicted to the opioid prescriptions that you just mentioned, and they can't get them anymore because doctors are working so hard not to continue the prescriptions, they become physically addicted, and then they want heroin. And the heroin contains fentanyl, which just like a kernel, not even a kernel of rice, like a piece of sand can be enough to kill a person. So it's devastating, and that's why the number of deaths have gone up. And it also keeps people more addicted too. It's so powerful.
Yeah, and I sort of look at fentanyl as a thing that is sort of like the morphized version, the changed version of something that was already really bad for people. So the fact that this is worse is something that's really hard to sort of come to terms with, because you sort of feel like you're fighting against something that is so powerful, that is so hard and hurts so many people. And just to put the numbers out there, just so people can understand the gravity of it, that the National Institute on Drug Abuse actually looks at synthetic fentanyl, and it is 50 to 100 times more potent than morphine. And that in itself is something to sit with for a second, and to understand that this is not something that can be played around with. It's not something that can be dabbled into. It is really something that if you use it once, then that's it for you. So that is a lot to take in, but it is something to understand. Also, if anyone is interested on how the opioid epidemic and the addiction that we are seeing in today's society and in today's youth, for that matter, there's a great YouTube video on TED Ed. Anybody that knows about TED Talks, actually, this is their education channel, and they are an immaculate source of information because they pull in from so many resources, and their evidence is always so empirical that we can use it to explain a lot, but also to really understand it in a way that is packaged, that is simple, but also honors all of the information it takes into account. So I'm not going to click on it now, but this will be in the description below, and please watch it because it is a really interesting video, but also just a really good part of the conversation that you could possibly be having. So what is an overdose? This is something that I don't think happens to enough people for them to understand, and that's okay, and that's a good thing. But when people think overdose, and especially when I interact with my youth, especially as a prevention educator, they say overdose is when you're about to die, or overdose is when you're about to go to the hospital. And in that right, I think that what we need to understand, that youth may not understand, is that an overdose is anything above what is recommended for your body. And what that means is if you are recommended 2 Advil every 6 hours and you take 3 Advil every 6 hours, that is an overdose, because you have gone over the dose of what your body needs and how it is meant to function, and how the doctor says that it will interact with your body, because the doses are meant for all the things taken into account, such as your metabolism, your age, your weight, all of those sorts of things. So that is what professionals define as an overdose. And there are many different types of overdoses that people can sort of discuss, and why we're going to have an interesting discussion on it, because there's technically things called accidental overdoses and intentional overdoses. And accidental overdoses usually are amongst children who take medicine that they're not supposed to, and they may take too much or get into something that is meant for their parents or their grandparents, and they take it, and it's not good for their body, and that is technically an overdose for their body. So that is the accidental part of an overdose, and this is usually from a lot of different things. But Vanessa, I was wondering if you could talk on the combination of what like the different parts of accidental overdoses is, because there could be something that you were taking, but you also partake in. So what's the discrepancy there?
I'm not sure exactly what you mean by that, Ruth.
Oh yeah, okay. So sorry, I coded language. My apologies. That's my political science background speaking here for a second. But alcohol and benzos, for example, or marijuana and a prescription drug. So what's the like? There's definitely a combination there. So what's the concern there?
Oh yeah. Well, yeah. I guess I don't know that I'm the most qualified person to speak on this. But basically, just yeah, when you combine certain things, it can lead to overdoses. I don't know, Rocky. Can you speak to this question? I'm not sure how to answer it exactly.
Yeah, so I'm the one who brought it up, I think.
Okay.
Okay.
Many times people are prescribed something from a doctor, and it could be an opioid for pain relief, but it could also be a benzodiazepine, which is typically prescribed for anxiety, panic attacks, highly addicting. And they have their couple glasses of wine. Or if we're talking about kids, they get a pill from somebody and then they get into somebody's beer or wine. It's the combination of the two that can cause an overdose. Those are unintentional. But I would argue that almost every overdose is accidental, because I don't think most people want to die. I mean, someone who buys some, what they think is Xanax from a friend, and they think it's just going to help calm them down because they're freaked out about an exam, but it ends up containing fentanyl. That's a terrible, devastating accident. But I've heard some doctors call it polypharmacy, combining just enough. Maybe even it could be just enough Benadryl combined with a benzodiazepine, combined with some alcohol, depending on your weight. Like, there's so many factors that go into this. The combination can be deadly.
Yeah. And what I find so interesting is that, especially when it comes to youth, making sure that they're not in charge of their medication, I think is an important part of that as well. That as a parent or as a guardian or as the adults in the room, to make sure that they're taking the right amount and that there's nothing else going on beyond that. Because I know a lot of times there have been, I know there are youth that do take Xanax, even though I say that it's too strong of a drug for people 18 and under to take, but people take it. And it does happen. And there are people that also take Xanax and experiment with alcohol, or take Xanax or, whatever it is, ADHD medication, and experiment with marijuana. And those are the sorts of things that we also want to address too, that overdoses they're not necessarily things that people mean to do, which, Rocky had stated, but also to say that it is something that happens. It's just something that happens. And when it's that instantaneous, when it's that sudden, based on one decision that somebody makes, then that is a scary reality. But it's also something that people need to be aware of, that in one decision, in one moment, those things can change for people. And that's something that I don't know if I'm very comfortable sitting with, but it is something that I think we all need to sit with. That's the information that is just empirical.
And
And
can I share one more thing?
yeah, of course.
My sister died at 39 years old, 6 days after her birthday, from an overdose. And she had the combination that I'm talking about. One of the things that she took was a commonly prescribed sleeping medicine. And what I found out later was that this particular sleeping medicine makes you black out. And so a psychiatrist explained to me that she could have taken it. And she also was drinking and had a Benadryl. Like, I was using that as an example. But the doctor said she could have forgotten that she took her prescription 2 hours prior. And that is a very, very common thing that can happen. One of the side effects can be a blackout for some of these medicines.
Yeah. Thank you for sharing. I know that's not always easy, but it's an example that we can use, and it helps further our understanding of what this means. And I think that's a great example of us saying that it's not just young people, it's every age, but people, for example, they may forget that they had taken their medicine. So people who are elderly may have heart medication that they need to take, and they forget they had taken it, and they take one again. And those are scary things. So making sure that we're monitoring people that may need it, that we are being intentional with the way that we interact with prescriptions and medication in general. I also wanted to touch upon THC, because marijuana is the new thing. And being a prevention educator is, I don't want to say a frustrating time, but it is a time where we're sort of looking at new ways to navigate our environment, especially with the legality of marijuana, the recreational parts of marijuana. So, and when we are talking about THC, a lot of people interact with THC as if it's not going to harm them at all. And okay, maybe it won't necessarily, it may take a lot in order to hurt you very much, to hurt a lot, to cause death. But that doesn't mean that THC is not something to take into account when you're talking about overdoses, because if you take too much, your reality changes. You may be nauseous. You may be using THC and taking another medication, which in turn exacerbates the side effects of both of those drugs. So making sure that when we are looking at, the harmless types of drugs that youth may see as harmless, also know that those interact with your body differently, especially if you're taking something else. But also knowing that I've had students who have had edibles, and for example, there's a misnomer. I mean, it's something that's kind of common, where you make brownies and there's THC oil in it, and they eat the whole brownie instead of only eating a quarter, which is what the serving size is meant to be. And that's the reality, that when we don't have the proper ways or proper channels of understanding what THC is or how it interacts with our body, then people just start experimenting. And that experimentation can possibly have really hard side effects, really hard realities to come to terms with if it goes any further and hurts them in a way that they can end up in the hospital. There is a great resource, the Poison Control Center of New Jersey. I will have the number listed below in the resources. That is something to keep into account. So if there is any youth that has THC poisoning or overdoses on THC, that they can call this number and sort of go through the process with the person on the line who was non-judgmental, and just make sure that they get the help that they need. And just, monitoring the use of any sorts of drugs with youth is good to know. But in general, that's what we should sort of address. Anything to add upon that? Okay. So why do people develop a substance use disorder? I always talk about ACEs because it is something that is so much a part of the way that people interact with their environment. It is something that the body just remembers. It is something that we look at a lot. And it is something that interacts with our public health. And so when we have adverse childhood experiences, I have a whole presentation on this. So I will take that presentation and also cite that below. So just, for that purpose. But is there anything to add for ACEs on anyone else? Anything to add to that?
Just that there's so much data to support that as your ACEs score increases, your likelihood to develop a substance use disorder increases.
Yeah. And thank you for that. And also to, it's not just substance use disorder, it's heart disease, it's cancer, it's so many different types of things. So just to keep that into account and to understand that sometimes people really are fighting against a lot of things that we don't know about, and to be gentle with the way that we approach them in their substance use disorder. There are many different ways that we can talk about this, but mental health disorders also play a role, such as Vanessa said before, that 50% of people who have a substance use disorder also have mental health disorders. A really bad day can lead to a lot of different things. So we just want to make sure that we're taking people's status into account as well. Genetic predisposition. So Rocky, did you want to talk about this a little bit?
Yeah, I mean, again, there's substantial data and evidence to support. I mean, you can talk about twin studies, and if you have one parent that has an alcohol use disorder, or a grandparent, or two parents, like, we know that there is a genetic predisposition. Doesn't mean you're guaranteed to develop substance use disorder, but especially in prevention, it's important to know and to let your kids know that there is a family history, and that you may respond differently than someone who doesn't have this genetic predisposition, and you are more likely to develop a substance use disorder. That is a fact. We know that now. And it's just another risk factor.
Yeah. And to know that and to discuss that with your family and to discuss with the people in your family in general is to be a mitigating factor, to take that risk factor and turn it into a mitigating factor, because you are addressing those things. So having that conversation can really flip that into being aware of it and making sure that people do what they need to do. I also say that, when we have substance use disorders, and I've brought this into our conversations before with Rocky and Vanessa, that a substance use disorder is just a maladaptive coping skill on a situation or in a situation that may be hard for someone to face, and they just find those resources, and that's that. And that substance use disorder got you through the hard times, but now it's time to address all of those things that are underlying. And so using substances is just maladaptive, but it is a coping skill. It is something that helps someone get through hard things. Rocky, you talked about this in particular, but the physical and chemical dependence, even when someone doesn't have a high ACEs score or mental health disorder, there's still some stuff that can happen there. So would you like to talk about that more?
Well, I mean, we know benzodiazepines, for example, it may go back to your maladaptive coping skills. It may help calm down anxiety, but because you develop a physical dependence, you need a higher dosage and a higher dosage and a higher dosage, because just the drug itself, regardless of all these other issues, is physically addicting. Same with the opioids. And as a result, that also means that, and alcohol is the same way. If someone has alcohol use disorder, alcohol is addictive. You build up a tolerance. That's a classic example of addiction. And benzos, those two things can kill you from withdrawal, because you can develop seizures. That is a physical dependence, even if the rest of your life is perfect and you have a 0 ACEs score. So that's why we have the opioid crisis that we have today, because people became physically dependent on the prescribed opioids. And then when they were taken away, their body needed it, craved it.
Yeah. And, I read a study that said, I believe I may be misquoting this, and I'm going to cite the study below, but it said 25% of people who were addicted to fentanyl started off with opioid prescriptions. And so, I mean, I'm sure that number is relatively accurate, because that sounds right. It sounds like there are people that start with one thing and end with another just because of their physical dependence on that substance. And also, I always have to bring in youth, because that's the majority of the population I work with, and youth mostly is prevention education. Obviously, you can do prevention education at any age, but to understand that youth are especially vulnerable to these sorts of things. So When we say consumer, we mean someone who uses substances in a way that is not good for them, and consumes substances in general. So when we're talking about youth, we're talking about the environment that they exist in. And this means that the environment that they exist in, they only look towards the resources that are around them, regardless of what that looks like. So these resources may only be substance use disorders. These resources may only be, alcohol, or these resources may only be, taking risky behaviors or engaging in risk factors because of the environment they live in, because they may be in a bad area of town. Communities of color have higher rates of substance use disorder because of the racist history that exists there. There are many different areas that a youth exists in, and to make sure that the resources that they have are good, the resources that they have are consistent, and the people in their lives are dependable and be able to be dependent on. So these are all things that are keeping in mind. And what about a youth who is around substance use disorder? This sort of means the same thing, that if they are around it, they are more likely to engage in it, and to make sure that if they are around it, then there is an earlier point of intervention to make sure that they get the resources they need so that they do not develop their own substance use disorder, and to get the help that they need, because being around substance use disorder can be very traumatizing as well. And we will talk about that. So I'm thankful that Rocky and Vanessa will be talking about that very soon. I believe in the next slide, if I'm not mistaken. So how are families affected? Vanessa, especially, you're working with families, you're the family advocate. So how are families affected right now with everything?
Well, a lot of families are feeling overwhelmed and exhausted and have been, through this for a long time. I think Rocky's going to follow up on some of that too, and I'm going to talk a little bit more about our services.
Yeah.
I think because I'm a person in recovery, I'm also a family member in recovery, I can look kind of through both lenses. And what I've found is that the family members who are living with a loved one, or they don't even have to be living with them, but they have someone in their family who they love very much, who has a substance use disorder, they are having the same feelings and the same experiences. They are experiencing the shame, the fear, they feel isolated. Sometimes they have the same kind of denial. They're certainly stigmatized, or they feel stigmatized. Sometimes we say these are illnesses that people don't bring casseroles to your house for, which is really sad. They suffer from physical health issues because they haven't been taking care of themselves, because they're so desperately trying to save their loved one's life. So that's how families are affected. And because our behavioral health system is a little broken, I have to say, it's not as robust as I would like it to be. Families in particular end up filling that huge gap. But I'm grateful that New Jersey has invested the money and offered this grant money to provide support to families now. This is the end of our third year.
Yeah. And, I just wanted to take a minute to explain a little bit more about our services. We offer services in Mercer County. Well, we have some other counties that we cover too, but specifically we're talking about Mercer today. And we have family support coordinators. We're available for, we offer, our services are free, confidential. We offer one-on-one supports. We have weekly family support groups. We offer Narcan, naloxone trainings quarterly. And we're available, email, Zoom, text, phone, and we can do in-person meetings sometimes too. So we have a lot of support available to families that are struggling. And we use a craft strategy. So basically that's kind of, Rocky was talking earlier about, she mentioned the tough love and how we don't ascribe to that anymore. It's kind of the opposite of tough love. And we're basically, we're realizing there's a little bit more gray, and we're kind of using the idea that we're encouraging positive reinforcement, positive communication, and teaching people how to keep those lines of communication open and, allowing for natural negative consequences, but not cutting people off, and kind of teaching some of these skills through this model. And all the while helping people to practice self-care and take care of themselves, because it's important when you're, taking care, you're helping a loved one, that whole idea of putting on your own oxygen mask before you help someone else. It's kind of a strategic thing. You have to be able to, you can't help someone else if you're running on empty yourself. I don't know if you want to add anything to that, Rocky.
No, I think one of the most important things you shared, Vanessa, which is the essence of craft, is that if you can keep your family member engaged while setting boundaries for yourself, so you keep yourself safe, you keep your home environment safe, there's a much more likelihood that you can offer help when that opportunity presents itself. And CRAFT has been utilized as community reinforcement approach to family training is what it stands for. And it's been utilized in Europe for a very long time. It's been around for 30 years, and it's becoming more popular, finally. There's a lot of evidence behind it that it, at a minimum, even if you can't get your loved one into treatment, it's proven that the levels of anxiety and depression for the family member, the caretaker, decrease. And you can only help someone else if your cup is a little more full. So if the family member is healthier, the family system may become healthier, the opportunity to help their loved one increases.
We have a question from the chat, just a quick one. Is there a formal craft training program and certification?
There is a training program that's offered to people. So we're certified peer recovery specialists, and basically we offer peer support to family members. There is training that we're required to attend. I am going to offer, and I'll share it with you, Ruth, like a 10-week series that will be a little different from our support group, but that will focus on a craft strategy every week and do worksheets and then share our experiences with it. I'm probably going to start that in October. I don't have the exact date. It will be virtual. So I will share that information with you.
Thank you. That's always helpful.
And I just wanted to add one quick thing. They call craft a blend of science and kindness. I really like that because it's, I don't know, I just wanted to add that because I think it's a beautiful way of looking at it.
Yeah, and that sort of meets the last point here, that meeting people where they're at is exactly what organizations should be doing when we are interacting with substance use disorders. It's making sure that we honor their experience, that we honor where they are, and then give them the resources that they need based around their specific situation. So not pouring from an empty cup, making sure that we have family members all taken care of. Those are all parts of a system that help people pursue sobriety, but also pursue a freer life. So thank you for that. Those are all great things.
And we believe that families can be in recovery too. It can be on a recovery path. And so the prior slide where we talked about the genetic predisposition, not only does substance use disorder run in families, but recovery can run in families too.
And I think that's a great way of putting that I didn't even know, that's you giving people language empowers them, giving them labels can be something people can own. And, when I say, oh, I'm a family member in recovery, that has a different way of saying it. It's not saying, oh, my sister or my mother or my father, had alcoholism or, whatever sort of language people use. It's different when you use that language and that label. It empowers people to own their situation and to find resources beyond that. So I love that. It's just a great thing. And I think we'll be using that at the Mercer Council now. So thank you for that. So we'll be moving on from there. And what can we do? So there are a lot of different ways that we can do this. Know the signs of a substance use disorder, know who to call, know the resources in your area. understand what may lead up to a substance use disorder. We sort of talked about why substance use disorders happened. Stay involved in the lives of children that you can, whether it's your own children or just checking in on people in general. I would also say that social media has a huge part of that. I have two presentations on subtle advertising and social media as a drug. So you can sort of use those as reference when we're talking about this. But there are parenting controls you can employ. There are many different ways to monitor their behavior. I also have here, there is a med drop on NJ Consumer Affairs where you can sort of look through Project Medicine Drop and look at Dropbox locations. But the Mercer Council ourselves has Mercer County disposable boxes. So you can click on our website here. It's mercercouncil.org/safe disposable boxes. And you can click and it brings you straight to the areas that you possibly would need to drop them off, or you can call if you have any questions. So these are all hyperlinks. You can click on any of them you would like. We also, excuse me for a second. Anybody want to talk about Deterra for a second?
Yeah, I was going to briefly, I know it's 1 o'clock, but just real quick about the managing medicine. So I have my Deterra bag right here. Basically, it's almost like cat litter or something in there. And it's a way to safely dispose of medication. And you can just put it in the bag. It's good for like liquids, pills, patches. You put it in the bag and pour some water in, and then you seal it up and you can throw it in the trash. And it keeps the medications out of the water supply. You know, having medications in the water supply can lead to hormone changes and animals being affected. And so we just want to keep medications out of the water supply and keep unused medications out of the home. So that's for that. And then lock boxes, you know, obviously we don't want children or people who aren't prescribed certain medications to have access to medications. And we just want to, you know, I didn't, and I'll share a personal example. I didn't think about this. I had a teenage daughter who was struggling at one point, and she had taken some of my prescription psychiatric medications. And she ended up being okay, but I didn't think, this was a couple of years ago, I didn't even think to have them in a lockbox, which they now are. So, you know, sometimes people don't think about the fact that these are strong medications and we don't know who might, you know, get into them. So putting medications in a lockbox, and then also pet medicines, you know, pets can be prescribed pain medications, benzodiazepines, anxiety medications, and they're very strong medications, just like what people can have. So those are another thing just to be aware of. Definitely. I don't know if anybody else, if Rocky or anybody else wants to add to that, but those are just the quick managing medications.
Yeah. Thank you. Really good overview. So I do like to end my presentations. We also have contact information for Rocky and Vanessa. So if you want to stick around just to like screenshot it or view it, I will also be sending a screenshot of this to anyone who's on the listserv. So don't worry about not getting their contact information if you can't write it down quickly enough. So I have two quotes here, and I think these sort of are holistic and express things in a way that words that I don't think I'd be able to put together in this way. But one is, the way you heal the world is you start with your own family, and that's by Mother Teresa. And the second one is "No is a complete sentence" by Anne Lamott. And both, I think, speak very true to what we do here and the way we wanted to portray this presentation. Anything to add?
Thank you for this great opportunity, Ruth.
Yeah.
Thank you so much, Ruth.
Yeah, of course. So for anyone that wants to have Vanessa's information and Rocky's information, it is right here. I'm just going to leave it up just for a second, but you know, you can click the screen share button, whatever you want to sort of take a snapshot of this, but I will be sending it out, so don't worry about that. Next week, we will be talking about school and sort of how to help children interact with their environment at school again. So thank you for being here. Thank you for your time and dedication, and hope to see you next week.